is really actually a very exciting day because we have the chance to actually have Dr. Deborah Siegal here to actually give us the latest in terms of understanding of some of the aspects regarding bleeding and thrombosis. And so she's a associate professor of medicine at the University of Ottawa, associate scientist at Ottawa Hospital Research Institute. She's a graduate from McGill University, did her internal medicine and hematology at McMaster University, and she did her degree in pharmacology and health research methodology there as well. And we were so excited, and in fact, in 2020, we were on the committee to actually recruited Dr. Siegal here as a Canada Research Chair, which is really, very exciting in the cardiovascular domain, but particularly in terms of anticoagulant treatment of cardiovascular diseases. And so she's really a specialist in thrombosis, and we call on her team, for really all the conundrums that we have on the clinical side. And she's also scientist at the OHRI. And we do know that, blood thinners are very effective in terms of preventing thrombotic complications, embolic complications, but how do we actually, use them safely in our patients, which is always a very narrow fine line. And of course, there are new tools and new data and, sort of new considerations going forward. And her research really focuses on the management of anticoagulant-related bleeding. And I remember you also, has innovative tools, actually address some of the anticoagulants we use, and how do we actually manage the patient if there is a bleeding complications, and what do we do in the setting of urgent surgery, for example, for our patients, and also patients in situations where the patient had a stroke or have a concurrent cancer, for example. And her research is funded by CIHR, CanVector, Heart and Stroke Foundation, American Society of Hematology, and she's really actually, very well published in the area. And we truly look forward to her insight in this area and the update. So thank you so much, Deborah. Long awaited session.
Thank you so much. Very kind introduction, and it's really nice to be here. And I'm so happy to be here in person because I feel rejuvenated after that. And it has been a while. I came here mid COVID pandemic in 2020, and so it's really nice to have some faces and human interaction. So thanks for that. And I always like to say, better not to set the expectations too high, keep expectations low and then nobody's disappointed. But hopefully it'll be an enjoyable, 40 minutes or so. And the idea really is to generate some discussion and for me to introduce myself to you and the things that I'm interested in working on. And I'm always looking forward to opportunities to collaborate with people because that's where I think where the best science happens is at the intersection between disciplines. And I know this is the Research Institute, so I think you guys feel the same way. I just wanted to disclose that I've received honoraria for doing educational presentations from some manufacturers of anticoagulants, and it's all deposited into my account at OHRI, so I don't take that directly, but just so you know that. I was hoping that during this presentation, we will cover the following areas. That people in the room potentially could be able to counsel patients on the risk of serious anticoagulant related bleeding. I think this is, very common for people in the cardiovascular space. Apply best practices to restarting anticoagulation after gastrointestinal and intracranial bleeding. Really complicated area. I'll give you sort of a flavor of that and raise some questions in some areas for future research. And then finally apply, the importance of applying the principles of shared decision-making with patients and their caregivers and other professionals in order to make decisions for individual patients. We really don't have a lot of high quality data in this space. And so you're left with kind of, I'm the person with an expertise in something that nobody knows anything about. So it's a very interesting space to be in because there is a lot of, understanding or appreciating uncertainty and trying to be able to, work through that to make good decisions. I'm going to start off by setting the stage here, and hopefully this is familiar to people in the audience, but even in 2023, bleeding is the major complication of anticoagulation that limits the use of anticoagulants. And of all the people who require anticoagulants in Canada and in the world, atrial fibrillation is the most common indication by far. A second most common indication is venous thromboembolism, which is something that I see a lot, obviously, in my clinic, and then of course mechanical heart valves. And while we have had improvements in the administration of anticoagulation and the development of direct oral anticoagulants or DOACs, which or maybe people still call them NOACs, but the terminology now is usually DOACs. We know that the DOACs reduce the risk of intracranial bleeding. That's the most feared complication of anticoagulation, rare but really serious, high morbidity, mortality. DOACs also reduce the risk of major bleeding, however you define that in clinical trials. There is a suggestion that as a class, they increase the risk of gastrointestinal bleeding. There may be differences between drugs, but they have not yet been compared head to head, and there are ongoing trials addressing that. So although we know, again, all these benefits in comparison to warfarin, we still see, even in the DOAC era, the bleeding rates, of around 2 to 4% for major bleeding events. That's like you're admitted to hospital, you need a transfusion, you die of a bleed, there's a bleed in a critical site like the brain. Then also, another 10 to 12% of people have what we call clinically relevant non-major bleeds. This is actually I think probably an underappreciated and understudied type of bleeding where people actually have to, seek attention in the emergency room or go to their family physician, stop their medication, have an intervention like endoscopy. It's not, these aren't minor nuisance bleeds. These are real bleeding complications, and they affect quality of life. But of course, these vary according to the indication, the patient population under study. But just to say, this isn't a problem that's gone away, even in the era of DOACs. And it's helpful to remember that bleeding complications increase the risk of death. And then you can see on this slide on the left-hand side, hemorrhagic stroke, 27-fold increase in the risk of death in this one study, really serious. Subdural bleeding, still 7-fold increase in the risk of bleeding. But what I want to call your attention to, and maybe is underappreciated in routine clinical practice, is extracranial bleeding. We often focus in the outpatient setting and starting anticoagulants, for example, on, yes, there's this very rare complication of intracranial bleeding and, very rare complication. What's more likely to happen is that a patient has an extracranial bleed, like a GI bleed, gastrointestinal bleed, or genitourinary bleed. And you can see here that even extracranial bleeding still, increases the risk of death by 5-fold. And we see this across the clinical trials that evaluated DOACs versus warfarin for atrial fibrillation. You can see high mortality rates shown here. This is not a meta-analysis. This is just like the crude rates from the clinical trials. They're shown on the bottom. In dark blue is warfarin, and in lighter blue is the DOAC. You can see that for warfarin, the rates are around 11 to 14% death after major bleeding. And with DOACs, it's sort of 7 to 10% in these randomized clinical trials. Ideal patient population, high internal validity, right? These are not necessarily representative of the patients that we see out in routine clinical practice, but probably the higher rates that we're seeing here with warfarin reflect the fact that there's more intracranial bleeding. But just to give you a sense that DOACs still cause bleeding, and bleeding has bad outcomes. This is a nice sub-study from Aristotle, which was the clinical trial. People are probably familiar that randomized patients with atrial fibrillation to apixaban versus warfarin. And I like this slide because I think it nicely shows how severe intracranial bleeds can be. You can see there 43% risk of death within 30 days of an intracranial bleed. And that probably resonates with people, but what's maybe less expected is here, non-intracranial bleeding, which included, GI bleeding, GU bleeding, other kinds of bleeding, 9%. So that means if you have a major bleed that lands you in hospital, the risk of dying is up almost 10% for bleeds outside the brain. So very, and I think sometimes people are surprised when I talk about rates like this. They may not be dying of their bleed, but they're dying, very soon after their bleed. So I think sometimes that's an important distinction. What are the other consequences of bleeding? People probably see this in their clinical practice. There's an impairment in quality of life, particularly for intracranial bleeds where there's a lot of functional impairments. But even with GI bleeds, we've seen studies that have shown functional impairments or impairments in quality of life even up to a year after GI bleeding. So that's sort of an interesting and maybe unexpected finding. We know that anticoagulants are withheld from a significant proportion of patients who are eligible due to concerns about bleeding. So atrial fibrillation, we know still in the era of DOACs, 25 to 30% of people who are eligible aren't receiving anticoagulants for whatever reason. But usually related to bleeding. And then often we see people, who have bleeds on anticoagulants, those are discontinued after bleeding, even though they still have an underlying thrombotic condition And then finally, we see off-label use of the low doses of DOACs, particularly in AFib, where we know that the vast majority of prescriptions, for example, for apixaban are that low dose. But even in the clinical trials, there was a very small proportion of people who are truly eligible for that dose. So, over the next 50 years, we're going to see increasing numbers of patients who are eligible for these drugs. And so that means that bleeding is a growing health problem. And of course, on the horizon, which I didn't really get to in this presentation, because I'm not really sure where we're going to land yet, is the factor 11A inhibitors, the factor 11A inhibitors, which may have a lower bleeding risk, but the kind of jury is out and the studies are still being done. So we'll wait to see what comes. We're still years away from those. I just wanted to mention finally here about outcomes after DOAC-related bleeding. People may be familiar with specific reversal agents that can be administered to patients who have bleeding on a DOAC. We have specific reversal agents for dabigatran, which isn't used very much. I'm not sure. In our space, we don't see it very much. I don't know if you guys are using dabigatran. People are shaking their heads. It's not very commonly used anymore. And then for the factor 10A inhibitors, there is a medication called andexanet alpha, which is going to be coming to Canada, but is available in the United States and Europe and elsewhere. And in the interim, we don't really have a reversal agent. That's a whole different talk. We don't have a reversal agent for the factor 10A inhibitors. We sometimes give treatments like PCC or prothrombin complex concentrate as kind of a hemostatic strategy, right, to help people who are having bleeding. But you can see here in this slide, this is a meta-analysis, nice meta-analysis that was done that shows on the right-hand side, if you have bleeding patients and you look and see what happens to them, well, you know what, 80% of them stop bleeding, that's great. But look on the left-hand side, even if we treat these patients who have major bleeding, you're still looking at mortality rates, approaching 20%. So just to say, bleeding is serious, and I'm not sure we have as good a grip on it sometimes as we do on the thrombosis side of things. So when a patient, this is like me when starting out in this space. The reason I put that image on the front page, I forgot to mention this. I don't know if anybody's seen that documentary called The Dawn Wall, but it's fantastic. And these are images from that. It's about this guy who climbed, this impossible rock face. It's very inspiring, and I use it because I think of research in some of these areas of really difficult to answer questions, and I think about that. That's this guy who conquered this rock face. So I use that as like an image. But this is people. Patients had a bleed. Oh my God, what do I do? Clinging to this is him there. It's unbelievable, clinging to the rock. And I think about restarting. I think about bleeding on anticoagulants as kind of a framework, because I'm a framework-oriented person. If you know me, I joke about that a lot. And it really is, kind of a package of activities that you're doing. Prevention is the first step. You want to start a patient safely on anticoagulants, right? If they have a bleeding problem, you're going to treat that bleed as best you can. That may include reversal or hemostatic therapies. And then you're in this space here and what we're talking about today, which is reassessing anticoagulants after bleeds. And so we'll focus on that, but maybe some other questions will come up about some other types of strategies. But I think about this part of the pathway in relation to the rest of it, right? These things aren't things that occur in isolation. So the big question, and I think when I came up with this as a research area, this is something we get asked about all the time on thrombosis, and I don't know how many people in the room call thrombosis and they're like, when should we restart? And I remember being at McMaster and thinking, I have no idea. Because nobody really knows. And at the end of the day, we're all there because we want to do the right thing and make the right decision. But how do we do that? And so I started thinking about this as a way, to move forward in this space and try to answer some questions. But there is an unmet clinical need. There are no, randomized trials in this space. And we know that anticoagulants are permanently discontinued in many patients, not just those with intracranial bleeds, but also people with GI bleeds, which is sort of surprising. And so clinicians are sort of faced with, okay, well, what do I do now? Do I restart it? And if I do, when? And if I do, what? Those are all questions that come up. Most of the data are observational, and many are, most of it is also retrospective. And then we don't really know we don't know, much about a strategy. And because this is research rounds, and I think maybe we can talk about this a little bit more if people are interested, but there are a lot of methodologic challenges, with the data, sure, but also studying this area. And once you start to get into it, the weeds a little bit, you start to recognize, how much we don't know. even based on the data that we have. So a lot of the data is collected retrospectively, which means that it's really difficult to know for sure about drug exposure. Okay, so when we're saying a person comes into hospital, they have a bleed, a lot of the studies will look at cohorts of patients, and then did they restart anticoagulation after their bleeding within some time, let's say, of hospitalization, and we did this. But what you don't know is, like, did they take their drug? And did they take their drug continuously? And maybe they started and stopped, and maybe they switched to something else. So drug exposure can be uncertain and also time varying. So that's kind of another complex component. Determining the timing of follow-up is really important too, because what you want to do is make sure that if you're following people, you're sure that they've actually seen or been exposed to the drug of interest, particularly when you're comparing people who restarted and those who didn't restart. You want to know if those people didn't restart a drug and these people did. And sometimes that can be really tricky to sort out with retrospective data, particularly like administrative data. And so there's this concept of a mortal time bias, which comes into it in these studies, which is a kind of phenomenon that happens and can bias the results towards the treatment, make the treatment actually look good, because people have to survive in order to be able to get the medication. So you just have to be very careful about what you define as your exposure and when. And then finally, things like the competing risk of death. I mean, I just told you that up to 10% of these people die within a month. So it's really important to think about competing risk methods, and there are analysis techniques that use this, but not just death. There are other competing events that change the probability of a future event. So for example, if you have a patient and they have a bleed, then they'll discontinue their anticoagulant, which actually changes their probability of having a future thrombotic event. So you can start to think of some of the complexities of the data here. All that to say is that we did do one of these analyses. This was an administrative database study that we did as part of this work, looking at patients who are hospitalized, almost 7,000 older adults who are hospitalized for on anticoagulants with a bleeding diagnosis. And we looked at people who restarted versus those who did not restart anticoagulation after bleeding. And what you can see sort of in, what you can see in the green line is that people who restarted anticoagulants had a higher risk of bleeding and a lower risk of thrombosis. And we also see a lower risk of death. And so I would just caution, whenever we're looking at death, particularly with these observational studies, we know that these people at base, this is not a randomized trial. Clinicians were out there in routine clinical practice, giving people anticoagulants based on their judgment. And so the people who were in the group of patients who restarted likely had a better prognosis overall. So you just have to kind of take the mortality data here with a grain of salt, but makes sense. People who take anticoagulants have a higher risk of bleeding and lower risk of thrombosis. That's not very surprising. And you'll see that even if there's a lot of other studies that have shown this as well. This makes sense, right? But one of the things that we face a lot in this space is, when do we restart anticoagulation? And like, it's one thing, right? When I always say, well, why did they bleed? What is the bleed? And why did they bleed? And what did they do to stop the bleeding? All of these things matter. And so there is no real one size fits all approach. And probably the best approach is to look at different types of bleeds separately. And so I focus here on GI bleeding and intracranial bleeding, because GI bleeding is the most common single site of bleeding on anticoagulants, and intracranial bleeding is the type of bleeding with the overall worst prognosis. But it's really important to remember that in this space. So let's just start with GI bleeding, which is heterogeneous. I mean, there are so many different types of bleeding and they all have different implications. So even among GI bleeds, we can't necessarily say that someone with angiodysplasia has the same risk of rebleeding as someone with a polyp. That's just not true. And so it really does actually matter, which is where this one size fits all approach doesn't apply. This is a retrospective cohort study. Ottawa participated at some colleagues in Italy. It's a large cohort. We're going to do some additional analysis of this, of almost 1,000 patients with anticoagulant related GI bleeding. And it's a busy table, but just to show here, if you look at the top line, that's clinically relevant bleeding. So bleeding that's really serious, and then also bleeds that are less serious, but still require some sort of medical attention. And you look over time, right? Even if you start at 30 days, you think, 5% bleed. Okay, well, that seems like a lot. And then as you go forward in time, you can see that the rates of rebleeding, this is in the whole cohort, whether or not people restarted anticoagulants, but you can see pretty high rates of bleeding in general going forward. You also see the rates of thromboembolism lower than bleeding, but again, these are not necessarily equivalent types of events. Having an ischemic stroke where there's a significant risk of functional impairment is different than a GI bleed where you have endoscopy. So that is true, and it's sort of like the holy grail of this space where we try to understand how patients and physicians feel about or think about those two types of events. Like, how do we capture that research-wise? It's very interesting and complicated. And then you can also see here in blue now the risk of death, right? So 5% here within 30 days. I told you in some studies it was up to 10%, but you can see here over time, even within a year, 16% of patients die. That's really not a great prognosis. So just to give you a sense, again, these are older patients who are highly comorbid patients. We did a meta-analysis of all of the observational studies that were available at the time. This was before we did the big cohort study, which showed, again, if you have patients who have anticoagulant-related bleeding, those who restart have a higher risk of bleeding and a lower risk of thrombosis. And here you also see that mortality signal, although again, we're going to take that with a grain of salt. You also see here that in the green box that anticoagulants are stopped for more than 90 days in 40% of patients. Now, this may be better. These are older studies, but 40% of after a gastrointestinal bleed, like, to me, that was really interesting. Of course, you would expect some people to withhold anticoagulants after an intracranial bleed. The consequences of intracranial bleed, we just said, were so terrible. But so it's very interesting. Again, here, these are observational studies with high likelihood of bias. So the certainty of the evidence is very low, but still, these are signals that are consistent across studies. So what do we know about restarting? And not much. This is a study, one of the earliest studies of warfarin versus no warfarin after GI bleeding. And you can see on the left-hand side, there's the survival curve looking at thrombosis. And so people who restarted, almost none of them had recurrent thrombosis compared to people who didn't. And that's a really low hazard ratio, as you can see. And then on the right-hand side, you can see recurrent GI bleeding there was an increased risk here, wasn't statistically significant, very wide confidence intervals, but you can see that, among people who restarted warfarin, the rate and risk of bleeding was higher. So I would say probably here the effect on bleeding was not excluded. Here we're underpowered probably to look for that difference, and you can see that nice separation. So we always would say, okay, and maybe we do this when we want the data to fit our narrative, I don't know, but just to say, that's probably a clinically significant difference, even if it's not statistically significant, and that's also important. So absolute rates are really important to look at, not just these relative risk. And this is another study that looked at oh, sorry, I wanted to mention one more thing here, was that the rate of recurrent GI bleeding in this study was higher among patients who resume warfarin soon, within 7 days. So we have this sort of 7-day time frame. It seems like maybe 7 days is something to look at in the future, 12% versus 6%. Another study here that looks at the timing of warfarin restarting after GI bleeding showed that there again was a reduced risk of thrombosis, which you can see here in the graph among people who restarted warfarin. That makes sense to us, right? We know that anticoagulants reduce thrombosis, but then there's this trade-off of increased bleeding, and you can see here again similar risk of GI bleeding. But if you look at the time frame of restarting, the highest rate of recurrent GI bleeding was in the patients who restarted warfarin within 7 days. So again, we now have 2 studies that suggest maybe that 7-day time frame is something to think about. Overall survival, again, you could see that the patients who did not restart warfarin had the lowest overall survival. And again, we think maybe these people just had a poor prognosis at baseline, and that's why they weren't restarted by their physicians. Yet not randomized trial. This is out in routine clinical practice. So we found a similar trend in our cohort of GI bleed patients. People who restarted had a high risk of bleeding and a lower risk of thrombosis and lower risk of death. So I'm just going to tell you very briefly about my research program because I wanted to just let you know a little bit about how I was thinking in this space research-wise, but also because we're starting a study here that I wanted you guys to be aware of. So a bit selfish. I started out when I was early on, we did this meta-analysis, we did it in a database study. I was interested in physician values and preferences, like why are physicians choosing or not choosing to restart people on their anticoagulants? What do patients and their caregivers think? That's something we're doing right now. And the whole goal was to develop a trial to be able to test this and provide some high quality evidence in the space, but it's actually been pretty complicated to do that. So we did survey a bunch of physicians. We did focus group discussions, and we identified themes or factors that influence decision-making for physicians. And then we built what's called the discrete choice experiments, which is a really cool survey method that's quantitative, that's used like in marketing research to understand consumer preferences. So it's actually pretty cool. And what you can do is you end up being able to rank the factors that are important to people when making their decisions, and you can get a utility score out of that. So it's pretty cool. And what we found in 250 people around the world, different types of physicians, that the most important thing for restarting anticoagulation after GI bleeding was rebleeding risk, followed very closely by thrombosis risk. Although we also identified some preference groups within there. So not everybody had, not all of the factors were homogeneous. We did identify some preference groupings where people preferred, were more concerned about thrombosis risk than rebleeding risk, for example. And so then we also asked these groups of physicians, about four different scenarios of when they would restart anticoagulation. And so you can see this on the slide here in the scenarios. And so we had kind of, artificial scenarios and asked patients, when, based on thrombosis risk and bleeding risk. So I'll just focus your attention on the right-hand side. You see patients with low rebleeding risk, and almost there was like zero equipoise. Everybody wanted, if you have low bleeding risk patient, everybody was like, yeah, we'll start anticoagulation within, mostly within 7 days. Okay, so that's cool. So we focus on the left-hand side here in green now, and these are patients who are deemed to be at high rebleeding risk. And so we said, okay, what's the difference between people who are at high thrombosis risk and those who are at low thrombosis risk? And you can see in the top box that people who were at, so again, everybody's high rebleeding risk here, but people who had high thrombosis risk, most people were pretty keen to resume anticoagulation quickly within 7 to 14 days. So physicians were like, yeah, if somebody has a high thrombosis risk, we want to restart anticoagulation, even though they're at a high rebleeding risk. We're willing to accept that, that risk. But whereas if people are at low thrombosis risk, there was much more equipoise, right? You can see many people wanted to, restart within 1 month here, or some people would say, I wouldn't restart at all. So this kind of made me think of, before we undertake a clinical trial where we don't really even know what the baseline event rates are, we don't really know when to start people's anticoagulants, let's just do a pilot study to see if we can get people to follow a risk-adapted strategy to restarting anticoagulation after bleeding, GI bleeding. And so this is a study, we started it up at the General and the Civic. I want to bring it to the Heart Institute as well, because I think you guys see a lot of these, we see a lot of these patients clinically here, and you may see these patients as well, to say, okay, patients who have a major bleeding complication, if they're high risk of thrombosis, we would restart within 7 days. And if they're kind of at a more moderate risk of thrombosis, we would restart within 2 weeks. And you could actually restart whenever you wanted within that time frame and whatever you wanted within that time frame. But the idea really here is to just gather some prospectively collected data to help inform a future study. And so it's 3 months of follow-up by phone, and it's pretty straightforward. And we're really looking at recruitment. It's actually been pretty challenging to recruit these patients. So if we can recruit people from the Heart Institute, I'd be super grateful. And I'll do any talk you want anytime. And so we're also doing a patient values and preferences study to understand what the factors that influence patients in terms of their decision making. We've had some really interesting observations so far. We've submitted an abstract to ISTH, so I'll come back and tell you about that because it's pretty cool. Right now we're doing semi-structured interviews with people who've had bleeds and then trying to understand what factors are important for them when considering restarting anticoagulation and faced with those decisions. Okay, so I wanted to switch gears a little bit and talk to you about intracranial hemorrhage. This isn't my area of expertise in so much as the GI bleeding is, but it's really important and something that we get asked about a lot. And just to mention, there was similar uncertainty, but also perhaps the stakes are a bit higher in this case, and also there's randomized controlled trials on the horizon. But you can see this slide it summarizes the equipoise about restarting anticoagulation after intracranial hemorrhage. This was Yan Shu, who's one of our fellows right now, who's coming on faculty. And you can see there's just like a wide range of preferences about restarting anticoagulation depending on the underlying pathology. So for cerebral amyloid angiopathy, I think probably many people will have heard of that, very high risk of rebleeding, low bar bleeds. Many people would never restart anticoagulation here. That's like in the gray. Whereas on the right-hand side, head trauma, most people would. And the timing here varies, but many people would restart. But in a similar vein, if you look at observational data, you can see that people who restart anticoagulation, again, have a higher risk of bleeding and lower risk of thrombosis. And there's a mortality signal that persists here, but again, I think that's confounding. So what do we, again, we're really in an evidence-free zone here. This is a systematic review and meta-analysis of observational studies in the intracranial hemorrhage population. And the majority of these people, again, these are atrial fibrillation patients with spontaneous intracranial hemorrhage. So they're high risk of rebleeding. You can see on the left that patients who restarted anticoagulation have a lower risk of arterial thromboembolism. And here it looks like a similar risk of recurrent intracranial hemorrhage. Now, again, their confidence intervals are pretty wide, but you can imagine, again, people who are chosen to restart are probably, perceived to be lower risk of bleeding overall by their physician. So really tough to say and need a randomized controlled trial to sort that out. So here's an example of a clinical trial. This is a pilot trial that was conducted by a group. So this is a pilot phase trial done at 67 hospitals, and they enrolled, how many patients here? Like 200 patients. So, really rare and hard to study area. So kudos to the people doing this work for sure. But what you can see is in this trial, these are patients with atrial fibrillation who had spontaneous intracranial hemorrhage, and they were randomized either to restart anticoagulation or to avoid anticoagulation. And actually in this pilot trial, it was not non-inferior. So it actually didn't meet the pre-specified criteria for non-inferiority. So it was worse. But if you look here in the blue box, you can see that if we're looking at the outcome of recurrent intracranial hemorrhage, that in the patients who resumed anticoagulation, there was 8 events versus in those who avoided anticoagulation, there was only 4 events. Okay, so higher risk of intracranial hemorrhage. But now if we look at the ischemic stroke outcome, you can see that there were way more ischemic strokes among the folks who were randomized to avoiding anticoagulation. So it's an interesting clinical conundrum. Both are bad outcomes. And I know that there's groups that are looking at other groups that are doing randomized controlled trials in this space, but which kind of at the end of the day balances out is a bit tricky to tell. And so they're going on to do a full-scale randomized trial that I believe is underway. With regards to timing of anticoagulation after intracranial hemorrhage, again, nobody really knows because the data it's really tricky. This study was conducted, this is an observational study, and they sort of looked at the 3 kind of outcomes and said, okay, well, we'll pick the time frame where there's like the lowest risk of recurrent thrombosis and bleeding and vascular death. And that was around 7 to 8 weeks. And so that's what kind of shows up in the guidelines, which I'll show you in a minute. And this is another study that this is Majid and who did this with Dr. Schulman from McMaster. And you can see that again, they chose a time frame where it looked like the combination of bad outcomes was lowest. These are again all retrospectively collected data. And this actually was a much longer time frame. So they were looking at kind of like much further out for the combination of these outcomes. So I think the guidelines will now say in patients who have atrial fibrillation and spontaneous ICH that, that anticoagulation resumption may be considered weighing benefit and risk. Really, this is challenging to do because that's precisely what we don't really understand. But again, it gives you this out to be able to talk about it with patients and kind of explore that uncertainty. And then if you're going to do it, they're suggesting that maybe 7 to 8 weeks is the right time frame. That's pretty late, actually. And I find in clinical practice, I don't know about you guys, but most neurologists want to restart that sooner. And then finally, left atrial appendage closure may be considered for patients for whom the risk is just too high to restart. So here we have a slide that shows a whole bunch of randomized trials that are coming, which is pretty cool. And we'll have some trial data in this space. And some of them, I think Enrich AF is actually being conducted here. So you may have patients that are enrolled in that trial. That's edoxaban versus no anticoagulant. There, second row from the bottom. So just as we're coming to the end, I wanted to include a couple of slides about patients who have contraindications to anticoagulation. And I ran into Ben Hibbert today and was like, you have to come to talk about this. So, we sometimes think about this in thrombosis, but probably not often enough. And I was wanting to get the sense from the group, you know, is this something that you guys are seeing more and more? Patients being referred for left atrial appendage occlusion after they've had a bleeding complication and maybe they're deemed to be ineligible for oral anticoagulants on a background of AFib. And so the guidelines are now suggesting percutaneous left atrial appendage occlusion for patients with AFib who have an absolute contraindication. I guess here the tricky part is, what does an absolute contraindication mean? Who is that patient? I'm not sure we know. Maybe cerebral amyloid angiopathy is probably like the number one, but I'm not sure there's a GI bleed complication that would preclude somebody from getting anticoagulation at all. It might be a preference issue, which is okay, right? If a patient says, you know what, I'm not going to be scoped a fourth time, like forget it. I want you to close my left atrial appendage. You know, that may be, but I'm not sure. This contraindication thing to me is a bit uncertain. And so there have been some trials done. So I'm interested to hear if folks have comments on these. This was some recently published long-term outcome data from a trial that compared the left atrial appendage closure with Watchman or Amulet compared to DOACs in these patients. And there's some methodological limitations, I think, to these studies. But overall, I would say overall, you're seeing here the patients who are randomized to left atrial appendage closure have a lower risk. Here it was a composite outcome. I'm just going to make sure I get it right here. Composite outcome of cardioembolic events, cardiovascular death, bleeding, clinically relevant bleeding, which is all kinds of bleeding, and procedure or device related complications. And these were not blinded outcomes. So they're, you know, it's open label trial, blind outcomes aren't blinded. There's some issues here, right? For sure. But I think, you know, these are data that would be really nice to see in a larger trial with a more definitive patient population. These were patients who either could have had a breakthrough thrombosis, they had a bleeding event, they had a breakthrough thrombosis while receiving anticoagulation, and they also had to have a high enough, you know, thrombotic and bleeding risk in order to, but they weren't that high. They weren't, the patients, the risk of bleeding and thrombosis weren't that high. I think the CHADS-VASc score was about 4 there, and HAS-BLED was 3. So it'll be interesting to see what people think. So this was the intention to treat or modified intention to treat analysis. This was a non-inferiority trial. It's always really important and interesting that this was a post hoc per protocol analysis. You know, intention to treat analyses can bias the results towards the null, which is what you want in a non-inferiority trial. So it's actually pretty important to do a per protocol analysis. So they did publish that, but it was done post hoc. But you can see a similar sort of thing where there's a reduced risk of that composite outcome. And you're looking out here to 4 years. You can see the line start to separate after about 12 months. And just to show you, maybe we'll skip this one. The other study that I wanted to just highlight that was recently published is this, you know, an observational study, the Amulet Observational Registry. And we're seeing, you know, similar types of things that, again, the primary outcome of kind of combined primary outcome of thrombosis and bleeding and other things is lower in patients with left atrial appendage occlusion device. This was the Amulet. Again, so this was a propensity matched analysis. They had a registry of patients and they matched patients according to their CHADS-VASc and HAS-BLED scores. So there are, again, methodological limitations associated with this. Again, it would be nice to see a randomized trial in this space. And it would be nice to see a randomized trial for patients who actually have like bleeding to be able to understand that. But it makes sense to me. People who are on anticoagulants have a higher risk of bleeding, right? They don't make you bleed, they just make your bleeding worse. So that's not a surprise to me. So I think there's a lot of potential here. And maybe some others in the room can comment about ongoing studies, which I think are happening. But if we put it all together, kind of where we stand now, you know, I think it's helpful to have an approach. And I put this slide, we published this because I think it's helpful just to say, you know, okay, well, let's have a framework because I like that. And it's helpful to just guide practice because particularly when there's areas of uncertainty, you know, we can't really be dogmatic, you know, and you can explore other options. So it's really important always, I always ask, has the bleeding stopped? So, and sometimes we get asked to restart anticoagulation when the bleeding is ongoing, and that's not usually a good idea. So you always say, well, you can't really anticoagulate a patient for theoretical risk of thrombosis when they're actually bleeding. It's like, you know, the probability of rain is like 100%, or the HAS-BLED score is 100%, right? So that's really important. And if the bleeding hasn't stopped, then you need to go down a different pathway where you're going to manage that bleeding problem. And then really important to establish whether or not they have an ongoing indication. Less common for atrial fibrillation patients or mechanical valve patients, but certainly for VTE patients, there may be an opportunity to reassess whether that person still needs to be on anticoagulants, and we do stop occasionally in patients. So that's a different space, but it does happen. And then you're weighing this like thrombosis versus bleeding, and that's really tricky because that depends on a lot of things. But I think, well, what is the risk of thrombosis, and not just the number, like the absolute risk, but also the consequences of that? Because I think having an ischemic stroke is quite different than having a deep vein thrombosis of the calf. And the implications for patients are quite different. So it is important to think about, what are the consequences and what does that mean for patients, short and long term? And same thing with bleeding. If they had a bleed, what was done? Did they find it? Did they fix it? Is it going to happen again? And if it is, can they fix it then? These are questions that can be really helpful to understand, the future. We can't predict the future, but it can be helpful to understand what kinds of risk. So it's not just a number, which is, I think, where we get caught up in this sort of like Chad's Vask versus Hasbled, and it's a number. There's more to it than that, and it's much more nuanced. And you definitely want to talk to your patients about this, and their feelings about it may change over time. So some people right after a big bleed, it's scary. They don't want to be anticoagulated, but with some time they may come around to it. Not that you should force them to do that, obviously, but it just sometimes takes time for patients to think about it. And so revisiting things is okay. And if we're going to restart anticoagulants, then of course we want to do that safely and properly. And again, when is it the point where we, call up someone who does procedural interventions and ask about left atrial appendage occlusion? I don't know. I do refer people for this. I don't know how many others you guys get from us, how many referrals you get from hematology. And then this is kind of all of us, remembering that anticoagulation is like a long-term thing. These are high-risk medications, the most dangerous medications, and lead to the most hospitalizations and adverse outcomes there are of all the drug classes. So this isn't like a, see you later, have a nice life on an anticoagulant. This is like people need to be reassessed on an ongoing basis. And that means evaluating and addressing modifiable risk factors for bleeding, which we're probably not great at doing, but it is important to do that with your pharmacy colleagues, with family physicians, make sure that patients, if they have modifiable bleeding risk factors, then to make sure that those are addressed. We just got funded to do a pilot trial to look at starting PPIs in people prophylactically for preventing bleeds for patients starting anticoagulation. So we'll see what comes from that. And I'm going to end with this slide with some key messages. And again, so I love this photo. Cling to the wall. Key messages here are that, reassessing anticoagulation is an important part of bleed management. So it's part of the process, like it's part of bleed management. I put it at the end there. It appears that overall that benefit favors restarting anticoagulation for many or most patients. Not all, but many or most. And that not all bleeds are the same. So you really need to think about bleeds individually and get as much information as you can about the bleed type before making decisions, particularly when there's a lack of evidence. This requires multidisciplinary input. I've learned a lot of stuff from gastroenterology and neurology, neurosurgery about these things. And I'm not making these decisions on my own, for sure. And that I think decisions should always involve patients and caregivers. And I acknowledge all the time that there's uncertainty. And I think that they appreciate that opportunity, at least to be involved in the decision. And so thanks so much for your attention. I hope that was interesting, and I'm happy to answer questions, sorry, or ask questions.
I think, that was a really very important message to bring forward the level of risk these patients faces. It's the current gaps in knowledge, but also a lot of practical actually evaluate this together. So in terms of the ability to potentially address some of these, trying to gather evidence along, in terms of the studies, So I don't know if there are questions from here. Yeah, so Ben and
only easy questions.
Fantastic talk. So, I think the most important take-home message I get when I've seen your talks, I've seen your talks a few times now, and that I don't think we appreciate is just how bad bleeding is. it's not one of your key messages on the take home. But I found that surprising. And as I've gotten further along in my career, I've shifted from ischemic event avoidance by hammering patients with anticoagulants and antiplatelets to minimizing the time that are on it in higher risk patients. And I've learned that the hard way by causing patients to bleed. Yeah. I think, given the data that you've shown, you're highlighting restarting. I almost wonder if we shouldn't. And I see that all the time in cardiology. We'll often combine antiplatelets with anticoagulants because patients have multiple indications, and we're so worried about ischemic events, even though the rates aren't that high. The relative rates are high, but the absolute rates of our ischemic events are not that high, and the bleeding rates are very high. And the problem we run into, and you alluded this to, is how to do these trials. So the problem is we did ASAP-2 here. ASAP-2 was the trial in bleeding patients of left atrial appendage versus medical therapy. And it got stopped early because I think there was like 100 patients recruited across 50 centers over 3 years. So how do you propose that we do these studies so that we can answer these questions? Because it's incredibly difficult to answer these questions. And I wonder if we cause more harm than benefit by doing things, maybe even left atrial appendage closure, maybe we shouldn't be doing that either. How do you propose that we do these studies so that we can answer these questions so we know what the right thing to do is?
Yeah, no, thanks. That's, these are thoughts that I have all the time. And I think you have to be, right? You have to be like, think about paradigms. We all treat thrombosis, and patients come to us with, well, I guess with atrial fibrillation, it's the potential of a clot, but for the most part, patients come with a clot. That's their disease. They have a clotting problem. And if you ask, I think if out there, our focus has been on thrombotic events because that's what we treat and that's what we see, and that we're concerned about those outcomes. But you're 100% right. I think one of the big challenges is, I don't know if I have an answer necessarily, but one of the big challenges is that we don't really have a great handle on bleeding complications and the functional implications and the quality of life and the quantity of life implications, as well as we do for thrombosis. We just don't know how to measure it. We don't understand how to categorize it. A lot of these bleeds, for example, if you have a clinical trial and you're looking at major bleeding events, it's like you either die of your bleed, or you have an intracranial bleed, or you drop your hemoglobin by 20 grams per liter. And most of those bleeds are actually people who drop their hemoglobin by 20 grams per liter. So I don't know that that's a reason not to anticoagulate people, but yes, critical site bleeds and death is clearly a reason to. So I think until we get a good handle on that, it's a bit tricky. And I wonder a little bit about some other types of pragmatic approaches, maybe with more like, different types of trial designs, like maybe more pragmatic trial designs where you're implementing some sort of package, or a decision aid, or something, or a cluster. Exactly. I think that's probably where you're going to get at this. But I really think, and many of us really feel like our current definitions of, we have great definitions of MI, right? We have great definitions of venous thromboembolism, let's say, but we don't really have a great handle on the bleeding side of things. And we also are biased towards thinking more that thrombosis is more important just because of the nature of our jobs. And patients too are it's almost like, if you cause somebody to have a bad outcome, versus avoiding a bad outcome, it's quite different for both clinicians and for patients. So your point is well taken. I'll think about that with my career.
I think it has to be fun because individual patient trials, we've done a bunch of these now. And when a patient's had a bleeding complication and they're presented with an alternative, we'll almost always take the alternative. And if you tell them you're going to randomize them, they don't seem to be super keen.
Yeah, so you're right. I mean, cluster trials, I've just completed a large cluster trial in another type of area, but it's a really enticing option for really addressing some of these more pragmatic type questions. Yeah.
Yeah, thank you so much for a fantastic talk. And having just come off service last week, I think I probably saw at least 10 patients. So a pitch one would be that if a Heart Institute team isn't involved, I think you're going to get a lot of people that are bleeding, and the decision between the need for anticoagulation and thrombosis in terms of even recruitment for your studies. But I think another comment would be along the lines of what Ben said, but I think for us, I think we never want to necessarily cause harm, but I remember there was some work done by the team at McMaster and Gord Guy and and all, and they looked at decisions about anticoagulation versus stroke by asking patients. And that's literally what I was doing all of last week, is if you've stopped your acute bleeding, because nobody's going to anticoagulate in the midst of an acute bleed, and you usually give a few days, and then for some we'll kind of wean a little bit of heparin or inox and see, hey, did they bleed or not? You're asking the patients, like, what do you value more? Like, if you bleed, obviously it's not good, we have to hold the blood thinner, and then we have to give you some blood products, or you have a stroke, which may potentially have long-standing risks, and that's typically what it comes down to. And I don't know if there's like a line in the sand that we draw, but I think often it is the patient's preference to say, hey, I don't want to have a stroke over anything. I don't mind if I bleed to death. I don't want to have a stroke, and live with that. So I don't know if you can comment on that and how you incorporate these very challenging decisions in a randomized controlled trial or in studies, where, as Ben also has implied, like, people are probably going to be like, well, my preference is X, I don't want to be randomized.
Yeah, no, those are really, I totally agree. And yes, you did have a lot of bleeds last week on your service. I think, there are those nice data where they used like sort of standard gamble, where they didn't actually even ask atrial fibrillation patients. They asked like people who were at risk for atrial fibrillation, whether they, would prefer to avoid a stroke or a bleed. And people, the kind of big number that people say is like, oh, I would have, have 18 bleeds, GI bleeds before, to prevent one stroke. And those data are helpful for sure. And I think it showed those data, probably the most important finding for those data is that physicians and patients actually value those things differently. So physicians are more concerned about bleeding than patients are. That was kind of my take home. But I also feel like it's hard for people to understand, like, patients don't want to have a stroke or a bleed, right? They don't want to have anything. And so I think it's sometimes hard for them to make that choice. And I'm not sure that we're equipped to be able to counsel them on the true risks of bleeding. And in some of the studies that have been done, people weren't really told about, for example, mortality rates after bleeding and stuff like that. I don't think that is appreciated by us and probably by patients, but it's a good point. Yes, many people would not want a stroke because it's bad. 80% of people are, die or disabled. So I totally agree with that. But it just means that we probably, there is an element of patient preference. But is there a patient for whom the risk of rebleeding is so high that it's just not warranted? Or can we find another treatment? Maybe it's factor 11 inhibitor, in which case I'll be out of a job, or maybe it's like left atrial appendage occlusion. I don't know. Is there another kind of low bleed risk option? It's kind of like that holy grail of treatments where you want to try to find that balance. We haven't really been able to find that. Part of it is the methodology. Individual patient randomized trials are challenging. But what's the outcome, right? And this is what that gets at too. How do you even measure, like, what's important? Is it recurrent stroke or bleeding? What if they're both bad? Then which, so, and these composite outcomes, I'm not sure capture that well enough, but your point is well taken. So that's why I use this approach, which is, not that sciencey, but at least I think it acknowledges uncertainty, and leaves the door open for research and individualized decision-making. And things can change over time, right? So the other thing we don't know about is, what if a patient's risk factors are really well, so you have a patient and they're at risk of stroke and intracranial hemorrhage, and you really control their blood pressure and they're like really under, very closely monitored. You stop all their fish oil and ginkgo and ginseng and garlic, and that increase the risk of bleeding, and SSRI that increase the risk of bleeding. Are you then reducing their, I don't know the answer to that question, but those are the other things that I think about that are probably helpful.
Maybe I'll just ask a couple last questions, but this is totally fascinating. One is, I absolutely agree that these need to be individualized, and so doing the trial probably is actually a package approach, right? Because ultimately we're talking about a much more tailored, sort of individual decision making. And so one thing which I have to give you my bias in here, because I'm interested in biomarkers, and so I know there is a sort of previously in terms of looking at risk of bleeding, for example, GDF-15 is actually a very good marker, right?
Yeah.
And so it suggests to me that patients who actually bleed on the medication likely has an underlying substrate. And so it's an integrated marker of inflammation, right? And it really actually suggests that there is actually, so certainly bleeding can indicate underlying cancer, underlying inflammatory processes, and things like that. Now, whether that can actually help in some of the decision making, and that because it's interesting that you do see in some cases, after a week, right, the risk is actually diminished when it is suggested there is a transient process. in play there.
Yeah.
So I'm just trying to figure out, the patient who bleed is likely a different patient, right, than the patient who doesn't bleed. And whether the underlying, pathophysiology can be actually better delineated and therefore addressed, and then therefore, sort of change the risk versus benefit.
No, these are actually, it's a really good point. One thing that I was thinking about actually as Ben and Hassan were talking was, and I mentioned it briefly at the end, but it's probably the most important thing is that we don't really have a great handle on prevention. But if we could have a bet, HESBLIT, like how many of you guys use HESBLIT in your daily lives? Really interesting. We don't use it very much in ours, but it's like the C statistic is like 0.7. I mean, it's okay, right? But probably your gestalt is maybe as good. But you're right. I mean, if there's a way to say, identify patients who are at risk of having a bleed better and implement prevention, because once you've had a bleed, to me, it's like the outcomes are pretty bad. And then we're into this like quagmire of what do we do? But preventing the bleeds in the first place probably is where the money's at. We can identify people at risk, but we don't really know what to do with those people, unfortunately, right? We can say modify risk factors, look at their medication, all those things matter. But you're right, and maybe that we just have to shift our thinking in towards looking at novel ways of identifying patients at risk. And so that's a very, very good point. Yeah.
Yeah. So certainly. Oh, go ahead.
There has been in all the clinical trials, so you have to put it down.
Right. Yes. Yeah. I mean, and they track together, right? Thrombotic risk and bleeding risk track together. Yeah. It's a really, so that's why I wonder a little bit, when I set out to do this, I wanted to do a clinical trial to test restarting versus not in GI bleeding. And it just became like quickly apparent to me that we were not there, right? In order to be, that would have not flown because there's so much we don't know. And I don't know, maybe we don't need that type of clinical trial as Ben suggests, maybe we need to think outside the box at novel trial designs or other kind of paradigms to be able to identify these patients and or come up with safer therapies. But I think with, in the DOAC era, we were like, woohoo, safer drugs. And it hasn't really panned out quite that way. Maybe the factor 11s will be, but I'm not sure. Not if they increase the risk of stroke, right? So all of this has to do with that as well and be balanced against the risk of stroke and AFib and other clots.
So that's great. Yeah. So I think the point we land on, so as I mentioned that earlier, we certainly have a patient population, we think about these issues, tremendously. And I think one of the ideas of having you to come is in fact that, greater collaboration, in terms of this area that's, I think, super important for our joint patients.
Yeah.
And,
and that's, I think so it's cool for me to come and present.
Yeah, absolutely. Yeah. So I think, the idea is that we actually start a whole series of these conversations and the collaborations.
Nice.
And so this is a great start.
Thanks.
Of,
hopefully nobody was disappointed, right? Anyways, I'll come back anytime.
Yeah,
so I appreciate your attention and your interest. Thanks so much.
Thank you so much, and look forward to exciting, sort of collaboration going forward. Yeah.
Cool. Thanks.